We now move on to the featured debate of the day, superficial parotidectomy versus adequate parotidectomy. I call upon Dr. Arvind Krishnamurthy sir for moderating the session. Sir is a professor in the Department of Surgical Oncology at ADR Chennai. Now I call upon the debaters of the day, Dr. Aditya Joshipura sir and Dr. Abhishek Vaidya sir. Dr. Aditya Joshipura sir is currently working as a senior consultant at HCG Asta Cancer Center, and Dr. Abhishek Vaidya sir is a senior consultant head and neck surgical oncologist at National Cancer Institute, Nagpur.
Abhishek, you're going first? Yeah. I think this is a very interesting debate. Of course, a little bit of it was we had discussed earlier in the morning itself, but just looking forward for both your perspectives, and let's see how it goes, because they haven't really given a context to the thing, but ideally maybe this should be for, say, let me give a context, a 3 centimeter tumor in a superficial lobe of the parotid. Okay. Yep, I think so. That makes things a little more interesting. Like, no? Right. So you can also discuss the other aspects also.
Yeah, that
but
also robs me of my first
slide. It is more relevant to
this
context. So I thought, like, just keep this in mind for a 3 centimeter tumor. I'm not saying benign or malignant. Maybe you can take both of them. Then you can. So stage is yours, Abhishek. Go ahead.
All right.
And you're talking for the superficial.
For the more comprehensive.
The more comprehensive sort of. Yeah. Go ahead.
So, firstly, thank you so much. Thank you, Oncosurgery Master Course 9.0. And I think I represent all the delegates and the faculty who have come from outside and congratulating you about this labor of love that you built. This is wonderful. Thank you. We hope to keep meeting you here more often. So, that's the debate for today. Dr. Arvind sir has given me a context. The question is, should parotid tumors be treated with adequate parotidectomy or a more comprehensive surgery? Without that context, this would have been a very broad, blanket, all-encompassing question with several underlying issues and nuances. So we'll target that, the case scenario which you've given, and also around it. So let's do that. So Aditya and I, we share a very close bond. We are brothers. We share a sense of humor and many sensibilities. So this is going to be good. Right. So to begin with, we know that parotid surgery has seen evolution for benign tumors. It has moved from enucleation to recurrences, therefore going to superficial and total parotidectomy, and then going to lesser kinds of resections to decrease the morbidity. For malignant tumors, it has gone from radical surgery to less radical surgery. However, there is no concrete evidence to say that lesser is better. So this is my debate all about. So let's jump into the evidence right away. So this is from the largest meta-analysis comparing superficial versus partial superficial parotidectomy. 23 studies, close to 3,000 patients. Partial parotidectomy had lower operating time, lesser temporary facial nerve palsy, lesser phrase. Wait. Next slide will probably be in my favor. Further evidence, better systematic analysis. So ECD, which is extracapsular dissection, and partial parotidectomy had lesser, once again lesser. What am I doing? Did I write these slides in sleep? Oh my God, I think I'm playing straight into my enemy's hands. No, ladies and gentlemen, this was just a spoiler alert for what my co-debater is going to show you and how I'm going to refute that. So if I have to defend, I will. Though all the evidence is laden in favor of him, and this is his home turf. So this is my defense strategy. What exactly is a debate? Let's understand that. Is the nomenclature standard? Are we even debating with standard terms? Is the evidence good? Let's look at clues from anatomy and embryology. Is the issue of safety well addressed? Are complications really so overwhelmingly less in one surgery? And finally, drawing parallels. So what's the debate really? Let's understand that parotid is a diverse group of clinical conditions, a parotid node, a parotid mass. Most of them will be benign, 80%. Further, most of the benign will be arising from the superficial lobe. Deep lobe tumors, as it is, are rare. Even for benign, they are rare. Malignant tumors may represent a wide variety. We just heard a very eloquent talk from Dr. Kani madam, and they are all over the place. So diverse treatment for diverse tumors. Without this context, we are all over the place. So let's understand what are the no controversy situations. Small, definitely benign tumors arising from and limited to the superficial lobe. I raise the white flag, I concede to you, yes, lesser surgery. Controversy arises when the pathology is not definitely known. Benign tumor is completely involving the superficial lobe, so that there is no margin there. Primary deep lobe benign tumor involving both the superficial and the deep lobe, and malignant tumors. These are out of context questions. So if you look at the treatment decisions, in practice, controversial situations are probably slightly more common. So in the next few slides, we'll tackle these. Now is a nomenclature standard. This is a very busy slide, but I've put forth what are the most accepted definitions of superficial parotidectomy and less than superficial parotidectomy, which has been variously called as partial parotidectomy, adequate parotidectomy, extracapsular dissection. Now, even when you look at extracapsular dissection, several authors, varying authors and varying meta-analysis have regarded it in two terms, whether extracapsular dissection involves the identification and preservation of the facial nerve, or whether it does not involve the identification of facial nerve. So we are that, unsure about the terminology itself. So I'm going to quote 5 or 6 meta-analysis. Within those meta-analysis, some of them define this ECD as no identification of the facial nerve. Some of them identify with define as with identification of the facial nerve, and some of them define them as identification of the facial nerve using magnification. So that's how unclear the terminology is. So those are the differences. Let's concentrate on this morbidity part. Morbidity for superficial is moderate, and for partial or extracapsular is low. Whereas for all the other things, is selection necessary? For lesser surgeries, definitely. Is it a standardized approach? Not. Is experience needed? Yes, only in experienced hands. Is facial monitoring needed? No consensus across the board, but yes, occasionally. Long-term data available? No. So apart from morbidity, lesser surgeries will always fall short when compared to more conventional surgeries. And I believe there is a lack of good evidence. When we compare, let's say, comprehensive versus lesser parotidectomies, there is no level 1 evidence. There are no large randomized, well-designed head-to-head comparison of the two modalities. Most of the evidence is in the form of institutional cohort studies. Most of these have been retrospective. This has led to several meta-analysis. I could find at least 6 good English language meta-analysis and 1 network analysis, which Dr. Arvind referred to this morning. So if we look at evidence for surgery less than superficial parotidectomy, I said 1 RCT, 6 meta-analysis, including 1 network meta-analysis. This is the only randomized control trial, small numbers. It compared conventional surgery, which did not give a breakup of superficial and total, versus less than conventional surgery, and found that partial parotidectomy or less than conventional parotidectomy reduces the operative time as well as the morbidity. If you look at the meta-analysis and network analysis, there is a confusion in nomenclature, as I said. Many of them have cross-reported ECD and partial parotidectomy. Most of the studies further concern only one benign tumors. I give it to you that there is one meta-analysis of T1, T2 parotid malignancies. Further, they had highly selected cases. Decision about when to do a partial parotidectomy was completely the domain of the surgeon, which led to selection bias, such as smaller tumors and tumors which are away from the nerve. Further, selection bias was done by surgeons who had several years of experience and they were at the top of the game. Now, what happens if we remove this biases? So this is an interesting study from the Vienna Medical School. Selection bias was removed, the experience of surgeons was removed because all kinds of surgeons participated in this CATLED study. Big numbers, 895 numbers. Surgeons did not have discretion on the choice of cases. Look at now what happens. Recurrence rates for extracapsular dissection are thrice that of superficial parotidectomy. Permanent facial palsy is also more than superficial parotidectomy. Both are statistically highly significant. So that's what happens when you remove the element of highly selective nature there. Now let's take a few clues from anatomy and embryology. We know that parotid grows by the ingrowth of oral epithelium into the underlying mesenchyme, and the facial nerve then migrates, gland insinuates so that the parotid gland is completely enclosed by fascia. Now this part is not divided into superficial and deep lobe as surgeons do, or is not divided into zones as the European surgical guideline do. All of this is one composite gland. All other definitions, superficial or deep, now that's of the past, but even the ESGS, which divides into zones, are only for the surgeon's convenience. So histological features of the superficial and deep portions of the gland, as also the different zones as mentioned by ESGS, are identical. There is no anatomical separation between zones or between lobes. Late encapsulation results into the incorporation of lymph nodes within the whole parenchyma surrounded by the capsule. So, is this distinction into superficial or deep lobes or in different parts as by the European guidelines, is this merely for surgical convenience? Yes, indeed, it is only for surgical convenience. If you look at the lymphatic drainage, parotid gland contains about 15 to 20 intraglandular lymph nodes. There is dense interconnection of lymphatics between the superficial and the deep portions, as also the different zones. And in fact, the deeper part of the gland may contain as much as 2/3 to 3/4 of these nodes. So this argues for more conventional or more comprehensive parotidectomy to extirpate these nodes in high-grade cancers. Now, issue of safety and outcomes. Facial nerve functions, undoubtedly, when it comes to temporary facial nerve palsy, lesser parotidectomies will cause lesser dissection and therefore give rise to lesser facial nerve. But with regards to permanent facial nerve palsies, there's not much of a difference between lesser surgeries and more surgeries. Also, several studies have found that facial nerve function, as Dr. Ravidev so elegantly mentioned in the morning, is determined more by the depth of the tumor rather than whether your surgery is total or superficial. So the bottom line is that facial nerve weakness is not solely caused by the extent of surgery, and it should not be an excuse for performing lesser surgeries. If you look at surgery for benign tumors, I concede right away, lesser surgeries are the norm. Raise my white flag there. But if we look at surgery for malignant tumors, no head-to-head comparison, importance of margins, importance of intraparotid clearance, and therefore no or very limited role of lesser surgeries in malignant tumors. Further, pathology may be in doubt several times. We uniformly do not have as experienced and well-versed pathologists as Dr. Kania madam. So FNAC has sensitivity only about 80% when it comes to parotid tumors. Further, the ability to tell if these are high grade is even lesser because of the several benign malignant lookalike pairs there. So approach should always favor more comprehensive parotidectomy when the pathology is in doubt, because you do not want to be found out later of having done a lesser parotidectomy for a high grade tumor. Also, the issue of tumor grade, there is general consensus for the need of doing more comprehensive resections with neck dissections when the grade is high, and neither FNAC nor frozen section can be a foolproof, I'm saying a foolproof evidence of the high grade of the tumor. So performing partial parotidectomy for malignant tumors whose grade is uncertain is fraught with danger. Complications, I already said partial is a clear winner when it comes to less operative time, lesser temporary facial nerve palsy and lesser phrase. However, this comes from the WIT study and the CADLIT study which I quoted earlier. If not more, at least same rate of permanent facial palsy will be seen with lesser surgeries as compared to conventional surgeries. Further, and Dr. Arvind alluded to this in the morning, lesser surgeries, because they cut through the salivary tissue more, they lead to a greater chance of psilocele. Now, this is just philosophy, this is just drawing parallels. Thyroidectomy can be considered as surgery around the laryngeal nerve. Similarly, parotidectomy is a surgery around the facial nerve. Until recently, we were doing total thyroidectomy for all tumors which were more than 1 centimeter in size. This was in spite of the fact that survivals were excellent and there was a good adjuvant management. In parotid, the grade of tumors vary widely. We do not know how they are when we start to operate them. So the presence of the facial nerve within the gland should not deter us from applying the same logic here. Adequate training and meticulous surgery should render conventional parotidectomy safe and without morbidity. And with this, I come to my concluding arguments. Parotid is separated artificially by the surgeon into deep and superficial parts or different zones in relation to the nerve. Any portion or lobe has the same pathology and has the same likelihood of developing benign or malignant tumors or lymph node metastasis. Partial or lesser procedure should be limited only to definitely benign conditions which are arising from and limited to the superficial lobe. Adequate base of resection of even benign tumors may occasionally require you to go to the deep lobe resection. Further, cancer with potential to metastasize to lymph nodes in the parotid should be managed with comprehensive parotidectomy. Arguments for performing comprehensive parotidectomy in most malignant tumors are strong because the tumor grade may not be confirmed preoperatively, and we just heard Dr. Kani ma'am say that. Meticulous dissection and adequate training will help minimize the morbidity of conventional parotidectomy. And in the words of the iconic and the inimitable Dolly Parton, less is not more, more is more. So do not fear the facial nerve, grab the bull by the horn, and the only way to do it is to train well and to train from the masters, and we had such masterly sermon this morning from Dr. Kaustubh sir, And for further such sermons, do join us at FHNO 2024. Sorry, that slide is missing, which is for a couple of months away, but do join us there. And let me assure you that there is no more satisfaction for a surgeon, for a head-ending surgeon, than to do a good parotidectomy. I rest my argument.
So let me begin by a couple of caveats. I am the organizing secretary, so those who don't agree with me can leave right away. They won't be getting the certificates. I can assure you that much. Second thing is, by initially putting all the pressure on me, by saying that he agrees with me on a lot of points, the argument, as he said, he had nothing to lose and I have everything to lose. So if I mess up in my arguments, I pretty much stand no chance in a kind of a favorable debate. But wonderful points made, and it's very difficult to overlook these points. Right, so is less more in parotidectomy? Again, this is our team of head and neck surgeons. Firstly, what is the debate here? So types of parotidectomy is basically the debate, a superficial, radical and adequate. So what is an adequate parotidectomy? It's good enough margins taken all around for an extracapsular approach. Why do we have the debate? Firstly, it's the oncology part. Secondly, is the safety part. Third is the philosophy part. And then we just take a look at the data. Again, we had a common slide when we showed that evidence is like a buffet. You can choose whichever plate you want and fill your heart and mind with it. So let's see what we do. Again, I too will continue in the embryology part. So the thing is that capsule of each gland is formed later by the surrounding mesenchyma, and the process it is delayed in parotid gland, so it allows for integration of parotid ducts and lymphoid tissue. So parotid in itself contains multiple number of tissues, so just removing the parotid tissue by itself may or may not constitute a classical superficial parotidectomy as it knows, because the origin tells us the story that it's an extensive network of mesenchymal tissue that may simply be impossible to clear completely there. A historical perspective shows how the parotid surgery has evolved. Now this is interesting because Patty in 1954 said that inoculation is bad, all the facial nerve branches must be exposed, and he proposed lateral parotidectomy, which is the current exofacial or superficial parotidectomy. Klopp and Winship in 1950s showed that parotid has multiple numerous variable extensions. While these prolongations may frequently be removed in a subtotal parotidectomy, the margin of excision is so slim that no claim should be made for total removal of all parotid cells. Now in 1984, finally, Donovan and Conley reviewed the weaknesses of traditional parotid operations. Firstly, they said that the monoblock concept is violated in those instances where the nerve enters the tumor or in the deep lobe tumors. And often, that is in more than 60% of cases, the neoplasm is in such proximity of the nerve that some form of limited capsular excision must be carried out to preserve the nerve, which itself is kind of an extracapsular thing. Now, Line, Vandenberg and Yamashita et al. Also have spoken of partial parotidectomy, and O'Brien has spoken of a limited superficial parotidectomy. Thus, at present, all these surgical options coexist for a treatment of a parotid tumor and include from the least to the highest volume of resection, extracapsular, partial lateral, lateral, total with preservation of facial nerve and radical. Sorry. Anyway, yeah. So this was what Dr. Abhishek briefly mentioned, the ESGS classification. Again, it divides the resection into 5 levels. That is the division of 5 levels of parotid removal. First is the lateral superior, second is the lateral inferior, third is the deep inferior, fourth is the deep superior, and fifth is the accessory level. So these are proposed by the ESGS. So according to them, the definition of parotidectomy is there are 2 conditions that are needed for it to be called a parotidectomy. First is dissection of the facial nerve, and then second, at least one of these levels is removed. So the term parotidectomy should be used only when 2 of these conditions are fulfilled. Rest is extracapsular dissection, which is what we are doing. Abhishek bhai again mentioned the trial by Park. Again, I agree that it was related to benign tumors, but let's look at what they say. They clearly mentioned that in post-operative there is decreased sensation, which was clinically significant, a temporary facial nerve palsy, as he said, transient facial weakness, wound infection, all of them were kind of more in the conventional surgery part compared to the functional surgery part. And most important is a stimulated parotid salivary flow rate. It recovered up to 70% in those cases where a functional extracapsular dissection was done compared to a total or a superficial parotidectomy where it recovered to up to only 20% at the end of 1 year. So that was a clinically significant difference. The reason being told is that the Stenson duct is obviously ligated in most of the superficial parotidectomy case. So in those cases, the recovery of saliva flow may be reduced. Now normally, adenomas can project into the surrounding tissues, which is considered to be the cause of recurrence in benign cases. But to assume that when the recurrence rate of adenoma is say 1 in 256, it's I think a little too cautious, especially in the light of the complications that are involved. So I think even though this paper was based on the benign tumors, we can establish that lesser dissection means lesser complications, taking benign cases as the argument. Now, what has been the bugbear of this? It's always been oncology. So, what is the oncology part? Again, this was a paper by comparing, as Abhishek Bhai told, T1 and T2. He nicely skipped it. Let me go into a little bit of a detail about that. So, it was a retrospective data. 5-year overall survival was 88%, DFS was 77%. No significant difference between OF and DFS in both groups. Both groups is partial versus superficial or total. That paper obviously had its flaws, which were very nicely and elegantly put out. But the mean duration of surgery and overall rate of complications was significantly lesser in the partial parotidectomy group. And in the 22% cases that recurred, multivariate analysis showed that lymph node mets and LVI were the significant factors of recurrence and not the procedure itself. So there goes the recurrence argument too, if we are just talking about this paper with the limited data that we have. Now what about the advanced cases? The argument would have not made any sense, say 20 years, 30 years, 40 years ago, where the adjuvant therapy was not available with us. Now we have an adjuvant therapy which is dynamic, evolving and continuously upgrading. That adjuvant therapy is obviously not dependent upon the remnant tissue of parotid that is left behind. So in cases of high-grade tumors which have been completely removed, the role of adjuvant therapy also has a significant role. So at no point are we recommending an R plus resection of any kind, but if you can get a good cuff of tissue around it with a good margin, and of course pre-imaged lymph nodal metastasis which have also been removed, then adjuvant therapy should cover whatever the additional risk that we are taking may be having. So it's all about using tools at the hand and giving better results. Again, few papers. Lim et al. Reported favorable results of conservative parotidectomy in 43% with parotid gland cancers, including high-grade malignancies, that is 37%, with a 5-year OS and DFS of 88 and 79% respectively. We talked about the Park paper already. And then there was a SEER database by Li and Chuang. They said that total parotidectomy did not significantly increase the DFS and OS relative to partial parotidectomy in early stage adenoid cystic CA. Partial parotidectomy also showed no significant difference in recurrence and survival relative to superficial or total parotidectomy. And the incidence of facial palsy was lower in the partial group than in the total or the superficial parotidectomy group. Other complications including Fraze syndrome was also significantly lower for the partial group than for the total or superficial parotidectomy group. Now, whether this may apply to a scenario or not, this was also an argument, and I must concede that it was Abhishek Bhai himself who suggested this. Cost effectiveness. So, in the hands of an experienced surgeon, extracapsular dissection is shorter, less costly, and equally safe alternative to traditional superficial parotidectomy when treating benign lesions, said by Cato. Procedure time, anesthesia time and length of stay were all significantly shorter for extracapsular dissection compared with superficial parotidectomy. There was another paper, there was another meta-analysis. So in this meta-analysis that showed no significant difference in the recurrence rate between these two techniques, and based on the available data, PSP is therefore considered to be, that is partial superficial parotidectomy, is considered equivalent to superficial parotidectomy as far as recurrence is concerned. Other findings in favor were Fraze syndrome, salivary secretion recovery, and the effects of facial asymmetries or scar deformities was significantly more pronounced in superficial parotidectomy group because of the bulge that has gone away, according to both subjective reporting and objective assessments. So I think this is a slide where both of us concur, to be very honest. Oncological clearance is absolutely mandatory. Partial parotidectomy has lesser rates of facial palsy, Fraze syndrome, disfigurement and lesser operative time. The complications of the facial nerve palsy are permanent and the results of rehab are unsatisfactory most of the times and very expensive and time consuming. And as Ravidev sir and all the other experts have been saying since the morning, it is so obvious when a facial nerve palsy happens that it happens to be one of the most visibly impaired nerves when it is damaged. So data is emerging that is showing a trend towards less is more, and with the advent of excellent adjuvant therapies, high risk tumors should involve that rather than actually doing more. Thank you very much. As a rebuttal, sir, we have decided to issue a joint statement like most leaders in the world do. So that is what we are planning to do.
Oh, is it a fixed match already? then I can go and sit in the audience. Yes, sir. Yes, please.
No. Arvind gave you a very nice scenario to both. He said 3 centimeter, well-defined lesion in the superficial lobe will involve Anil. Now Anil has examined and he feels clinically it is benign. Facial nerve is not paralyzed. Our radiologist is confirming on the basis of ultrasonography, CT, PET and everything. And Kanare Madam was told that in spite of all these things indicating to benign, it is a mucoepidermoid carcinoma. Suspect. Now I want Anil to tell me in his vast experience how many times a well-defined facial nerve intact, well localized, imaging wise considered benign has turned positive for malignancy. Low grade. No, Arvind will tell. Anil will tell. नहीं ज्योति तो बड़ी आदमी है तो बोलती रहती तुम बोलो what is your experience?
On the number of times I got a benign pathology.
No, like this clinical examination is like this. You feel it is mobile, facial is not involved, imaging wise it indicates to benign, but it turned out to be a positive for malignancy mucoepidermal. How many times?
Maybe 10 to 20%.
Okay, now this is the reality that you have, both of you have this tumor, which you know that it is though looking benign, but actually not benign. To Abhishek, in this circumstance, it is positively, madam is not wrong, it is malignant. Would you do deep lobe also, will you remove by picking up the nerves, though the tumor is limited to superficial? My question is to you. And you know now, still you will do the adequate parotidectomy, though the facial nerve has nothing to do with. Because Ron Spiro told that the topography of the tumor decides the surgical extent and prognosis is decided by Madam Tanare, not by you. So now you tell whether in such situation you will still do adequate parotidectomy or resort to superficial. And Abhishek, in such situation, along with the superficial lobe, he will also pick up the nerve and take out the deep lobe.
All right. So, thank you very much for giving us that middle bridge in between both of us. That's superficial parotidectomy. I would do a superficial parotidectomy. Ron Spiro also said grade is more important than stage for salivary gland tumors.
But you pick up the nerve and do the deep lobe?
No. As long as I have enough margin on the deep aspect, I will not. If I do not have enough margin,
75% of the nodes are in deep lobe.
debate. So let me get back to that. Nodes are important if in a high grade malignancy. How often, and that's the reason I wanted to set that question up before the debate. How often can grade be told on FNAC?
That is Canada medical.
Right.
No, see, if we are talking of specific case like mucoepidermoid carcinoma, I believe in the new MSKCC grading system which considers mitosis and necrosis. So obviously on FNAC that is not going to be apparent. What I said, let me correct myself again if there is any miscommunication, that unless it's an obviously high grade tumor, okay, it may not be depicted in FNAC. There are FNAC, you should remember that unless I see mitosis, grade 3 nuclear atypia and necrosis, I will not be able to, most of the salivary gland tumors have their intrinsic biologic potential. The tumors that are graded are mucoepidermoid carcinoma. Adenoid cystic carcinoma is not graded, it is differentiated by growth pattern. Solid growth pattern more than 30% is considered aggressive. So I will not be able to see that growth pattern on FNAC. Third type of carcinoma which is graded is adenocarcinoma. Apart from these tumors, salivary gland tumors are not graded A. B, only high grade tumors one will be able to tell on FNAC. I did not say that I will be grading on FNAC. What I said is I will be able to tell you whether it is a very high grade tumor, meaning grade 3 nuclear atypia, abundant mitosis and necrosis.
Yeah, I think just to sort of set the context again. See, this scenario of this debate is applicable only if there is a smaller size. This tumor should be less than 4 centimeters ideally. So, in the sense, you have 3 scenarios. Either it's a benign, either it's a low-grade malignant, or it's a high-grade malignant tumor. So I think it is based on these 3 scenarios. And also the location of the tumor. So the philosophy is in a T1 or T2 low-grade malignant, you can do a partial superficial parotidectomy, and there isn't. The thing is that, and Aditya also mentioned that even a T1, T2 high grade also, you quoted 2 studies, Lim and Park or something like that, some limited sort of evidence. Even it's a high grade that you can possibly do what majority do is, if it's a T3, T4 benign, like, or in the sense in the terms of, size criteria, more than 4 centimeters, then the debate is not there. Even for a benign, you would possibly do a superficial parotidectomy. And if it's a high grade T3, T4, we would sort of, do a total. So I think these extremes are there. It's only in the less than 4 centimeter benign or T1 and T2 low grade that this debate will sort of, and your arguments you can sort of put forth.
From and limited to the superficial.
Limited to the superficial. That's the reason why I set it the context. Yeah.
Abhishek, why do you want to know grade?
No.
Why you asking her again and
that's the
again
same
for
thing I was
grade,
going
and
to
she's
tell.
telling us some 5 types of cells, 3 colors. Why you want to know grade?
So, let's come back to this question. For this case, I would do a superficial parotidectomy.
Not that. Is grade important when we manage?
Yes, grade is, for a known high-grade tumor, there is enough evidence, and it has also come into the ASCO guidelines. For known high-grade tumors, you would do a total parotidectomy.
No. With removal of the deep lobe, if you do
it has
not,
come into the guidelines.
please read the guidelines well. It says if the facial nerve is not going to put at risk.
Correct.
There is no compelling evidence to do a total.
Correct. So facial nerve put at risk by
There is
surgery.
no compelling evidence. You only do it if your margins are going to be compromised.
Correct.
Margin. If the margins are compromised, we'll take out the facial nerve also. If the facial nerve is involved and I'm doing the margin, when you are saving a facial nerve, taking a tumor off it, how can that cause a compromised margin? Just explain me. It's going through your tumor.
So I think we are talking 2 different things here. One is margin on the tumor. Second is a need for doing a total despite having got margin on the tumor without going to the deep lobe.
How
Correct?
many of you
For the first situation, you certainly are doing.
deep lobe when you've got clean margins? No one does it. The data is evolving, and ASCO guidelines clearly say there is data evolving on intraparotid nodes and there's data involving on margins. Both do not have a consensus. And they say that you only take out the deep lobe if you are compromising the margins or you are not placing the facial nerve at extra jeopardy when you do that procedure. That's the rider. It's like doing total versus hemithyroid. They say if in the belief of the clinician, radioiodine will help, you can do a total thyroid. They don't tell you. That means you take a call between 1 to 4.
Yeah.
No one says in ASCO guidelines.
Correct. So we are now looking at two scenarios. One, where without removing the deep lobe, you wouldn't get deep margin. This is certainly a case for.
The nerve has to go. And Aditya, you should have started your debate by saying when you have got a millimeter margin from the facial nerve, why to do more? Millimeter नीचे छोड़ रहा है तो ऊपर भी millimeter छोड़ना.
I think it's very clear that adequate partial parotidectomy for a benign or a malignant tumor, a small tumor limited to lower pole, probably is an adequate surgery given the grade or whatever the grade of the tumor is or whatever. The grade of the tumor dictates the biology, the prognosis, and the decision to do elective neck dissection. Having said that, the debate has to be there for a benign tumor in the mid portion, whether to do a superficial parotidectomy or an extracapsular dissection. That is where most of the general surgeons have been confused, and majority of the general surgeons have started practicing extracapsular dissection rather than doing a superficial parotidectomy. And even for pleomorphic adenomas, when you do, any size. This is one of the most commonest operation in the general surgeons, and they are being taught that in the teaching hospitals too. And this is where the risk of recurrence, even in the benign category, is going to be more.
I think the other aspect of the debate is the use of terminology. Again, this extracapsular dissection or nodulectomy also they call it. It's a very confusing thing, as Abhishek also mentioned, there is no clear-cut definition, and some definitions say that you don't identify the facial nerve, but you'll have to use a nerve monitor in such situations and all those things. So that's one of the more accepted terminologies. But there are some schools of thought to say that for a pleomorphic adenoma, please don't do a extracapsular dissection. Rather do something called as a partial superficial parotidectomy. In the sense wherein you identify the facial nerve and then you sort of do less than a superficial. So again, one has to be very, very careful in case of pleomorphic adenomas when you are doing a extracapsular parotidectomy also.
I put some we have to give a message at the end of this debate. We are putting some statements. Tell us if you agree with them.
Sure. Yeah, Punam, very quickly by the time.
One sentence. So, sir, with this all debate with so many terminologies, partial, total, then enucleation, so are we not saying, sir, ultimately it is adequate parotidectomy only, that we stuck to that term irrespective of the size, location, and accepting that the facial nerve, when not involved, we are going to save it. So it is as simple as that.
It is adequate whatever you do, even if you do a superficial parotidectomy.
It is a type of adequate.
By and large, the accessory lobe is never removed in superficial. You leave 15 to 20% of the gland on the face above the nerve, even in a superficial parotidectomy.
So,
that's an argument why all this came up. And these controversies are man-made. You just have to see that you don't handle too many nerves. Very often I do a superficial parotidectomy, but I don't go all the way tracing the top branch. I get the two divisions, zygomaticofacial, cervicofacial. I skirt on top and I don't divide the top two branches, and I go home and they're not coming with recurrences.
Absolutely correct. Also, a total parotidectomy is not total.
So the grade, now that's a different debate, and I hope that would have been a topic for debate.
Would that make a difference?
So my threshold now for a malignant tumor is to do some sort of a neck. And again, the ASCO guidelines are fuzzy, but they recommend that you should do a little bit of a neck. And they also write a line that most surgeons sample level 2. The nodes at the highest risk for recurrence are at level 2 and 3. 1 through 5 are at risk in a malignant tumor. So if it's positive, you will, in all my malignant tumors, I do 2 and 3. I send it for frozen section.
There only, you just have to
Pick it out. The other reason I do it, I bared the digastric very bare. So I come to the nerve fast. I don't need the 5 minutes. I need 3 minutes, because otherwise you start looking for the nerve before you've bared the digastric, and the depth causes the problem in finding. So I always send the nodes. And if the margins are fuzzy on the MRI, or my pathologist is kinder and tells me maybe a higher grade, then I'll do 2, 3, 4.
Okay.
For an N0. For an N plus, 1, 2, 3, 4, 5.
So coming back to the debate, we've just put a few brief recommendations based upon the existing evidence. We went through it together and we thought that this is most appropriate. If there are any disagreements, because we need to send out a message. At the end of the debate, we have to send out a message. Yeah. So for definitely known benign tumors arising from and limited to the superficial part, you can do a partial parotidectomy or an extracapsular dissection. The definition of extracapsular dissection, whether it's with the identification of nerve or without the identification, I mean, that's really fuzzy. But
No, there is a controversy for pleomorphic adenomas, considering that it has pseudopod appearances, to do an extracapsular dissection.
But then all the evidence predominantly is about pleomorphic adenomas.
Yeah, that's what I said, so sometimes to do an extranodal, extracapsular dissection for pleomorphic adenomas, I think very, very skilled parotid surgeons should do it, because sometimes what happens is, of course, despite the radiology, I think the intraoperative clinical judgment is extremely important when parotid surgeons do a extracapsular dissection for a pleomorphic adenoma. And they would convert an ECD into a partial parotidectomy if intraoperatively they find that they may be closed or there is pseudopod
So that
appearance.
message goes through for benign?
For the benign.
Yes.
So Abhishek, all this is correct. We agree with this.
We come to the ASCO guidelines. This specifically mentions the grade. We cannot not look at that and say, no, this is fuzzy, we are not going to follow
So read the last line of 2.4.
Yeah, it says, because of the risk of intraparotid nodal metastasis in high grade or advanced stage parotid cancers, surgeons should perform at least a superficial parotidectomy with consideration of total or a subtotal.
With consideration of a total or subtotal when the nerve is not at further risk. You have to show the whole
it's the next page, so I couldn't get it on a snapshot.
So that is the important point. But I'll give them a going home message. No extracapsular dissection unless you're a gifted and a parotid surgeon who does a lot. Whatever they fight, extracapsular dissection is taking 2 to 3 millimeters beyond the edge of the tumor, that you don't leave pseudopodia of the pleomorphic adenoma. It's a highly skilled operation. Most of y'all, when y'all do it, will do enucleation. Many people do it with magnification. It's very simple logic. You don't screw up more of the parotid, so you get lesser leaks. You don't handle more of nerves, so you don't get that temporary paresis. That's the reason why it came up, and it's logical. It's correct to do it. But you should be gifted to do it for indication 1.
Thank you.
Right. I will close the debate. I think we already overshot time quite a lot, and thank you, Abhishek and Aditya, for those. Yeah, organizing secretary, if you are permitting, then I have no issues. Like somebody. Yeah, please.
So still that is not clear whether if the tumor comes as high-grade mucoepidermal carcinoma, should we do a total parotidectomy or not when the nerve is not involved? We should not.
You can do it. I think for the next home,
I'll tell you, when I do a total, I do a superficial parotidectomy.
Okay.
Unless my deep margin is compromised,
Only then we should go
then
for
I
total.
do it. Or when operating, I see intraparotid nodes that I feel are involved, then I take out the deep. That's my philosophy.
Okay. Thank you, sir.
No, there could be a T3, T4 high grade sort of a tumors, and as sir said, like node. Yeah. Right. Thank you.